So Dr. Lynette Scott, Chief Medical Information Officer at Department of Healthcare Services, and thank you for the opportunity to be here with Ms. Baylor. So sort of to start with, the data sharing agreement with the counties, that's not about the collection, it's about the sharing of data already collected.
But so my understanding, and correct me if I'm wrong, we need to be able, first of all, I think we need to come to some type of agreement on what data we need to be able to prove success, number one. And then, so that's still a challenge. But we also need to be able to have a higher, we keep saying that penetration, we need a higher penetration rate of counties to be able to share that data. I understand they're two separate initiatives, but they also are related, correct? I mean, we need to be able to see the data to be able to see how we are moving forward with foster youth.
Right. So there's a number of different data systems that collect information. So one of the things we've talked about a lot with various folks, at the state, we typically have what we call administrative data. So it tells us, have the visits occurred, what is the diagnosis that occurred, what was prescribed, so, and in terms of what ended up being billed and what we paid for. So the data that we typically have at the state level is going to be that kind of administrative data, which gives us a good picture, but not necessarily a complete picture of what's happening with the children. So I want to actually echo the comments made earlier about the electronic health records to help distinguish between what we can do now and what we might be able to do in the future to get at your question of how do we know we're being successful. So with the claims data and the administrative data that we have now, there's the aspect of how many visits have been seen, but we can do more than that, and we're working on that as well. So, for example, starting to look at the diagnoses, people with diagnoses, whether it's hyperactivity, whether it's depression, whether it's other kinds of diagnoses like schizophrenia, what kind of medications are those individuals receiving, what kind of psychosocial services are those individuals receiving. So we're working on those kinds of measures which start to get at your outcome. So for a given diagnosis...
Can I ask you, what,
yes,
I guess, and I don't mean to interrupt, and not at all trying to be pushy on this, but when you say you're working on it, so we're collecting data like... we're not collecting data of what psychosocial services do children access prior to being prescribed medication, correct?
We are collecting data around psychosocial services, again, in that
prior to being prescribed medication.
Correct, because if we're paying for the services, and so the part that's taking a little bit of time to work through in terms of how we do reporting is looking at those services, comparing against the timing of when we paid for the medication, and then being able to compare the two against each other to say were the services happening at or before the medication or after the medication.
So how do we track that if we can't? So I guess I'm just confused, and again, I appreciate your patience. If we can't track the basics of medical records going with kids, so how do we track what they're prescribed in the past?
So what you're highlighting is one of the limitations. So to the extent that we have paid for it, we can track that in our administrative data, and that's part of what we're working on doing, so we can share that information.
But when you say working, and again, I'm not trying to be pushy, does that mean we don't have a system?
We have information, and we're working on compiling it and connecting it.
I just wish you'd, look, I just want you to answer my question directly. Yes or no?
We have the data. We haven't finished the analysis to publicly report it.
Okay. So how do we have the data if counties are telling us, so if we have a kid that is in San Joaquin County, and then they're moved to Mendocino, for example, and they don't have their medical records.
So I want to distinguish, though, again, what I said yes to was the administrative data. What we don't have is the electronic health record. Okay. And so that's really the complete view on what's going on at the clinical level. So that's why we have to continually kind of give the qualifications around what we can do with the state data, with the administrative payment data, as opposed to the electronic health record or the medical record. That's the clinical data that's available at the point of care.
So we're using the data that we have, how we're spending via Medi-Cal.
Correct.
Okay. And, all right.
Correct. Now, the part that I want to extend on that, though, for the future, because the conversation you were having earlier, I think, is an area we really would like to partner and work with everyone on, is we have had the Electronic Health Record Incentive Program for the last several years and have provided over $1 billion to providers in the state to adopt electronic health records. Part of that is electronic health records that should be able to share the health records when patients transition from one provider to another. And so, as was mentioned earlier, the basis to be able to start to really share this information as it needs to be shared is getting to be there. But there's still a lot of challenges around making the systems talk to each other, about where do you house it when the child moves from place to place, and around an understanding of the laws, and that the laws actually do support the data sharing and they don't actually block it. And there's a lot of misperceptions around that as well.
So just a few items, and just looking at what other states look at as variables to success. And I just want to, and again, I'm not trying to single you out, right? So just trying to be able to get information.
Happy to give it a try.
So where other states are looking at is, were there delays or interruptions in psychosocial services? Do we track that?
We do not track that now. We would be limited in some of the ways that we can track it, again, because the billing data we have that may not be 100% complete in terms of what's actually occurring. And that's where we would want to engage around how we better track the clinical data at the county and local level.
Are dosages appropriate and safe for the youth? Do we track that?
So we can look at that from a general perspective, but we can't get to the specifics because some of those pieces involve knowing more detail about the child than we have at the state.
Because it's at the county level?
It would be associated with the medical record, right. So lab results, height, weight, et cetera.
So we are unable to track that at the state?
Not in a complete way.
Right. Okay. How long are children staying on medication?
So we are taking a look at and have provided a number of data analyses over the last year around children taking medications over a period of time.
So currently, are we tracking that?
Yes.
Okay. So we're able to access that?
Yes.
Okay. Another one that states are doing, which psychosocial services, providers, and placement types are the most successful preventing the need for medication?
I don't think we have enough detail to be able to do that, especially because of the complexity of the environment in terms of the different kinds of placements as well as the different kinds of treatment modalities.
So what I would love to be able to do, and again, I know all of you are working on this, right? And I know the director inherited this, and we've talked about this at the last hearing. But we're talking about, and I know this is very personal for all of you, we're talking about a person's life, right? Mm-hmm. We got 63,000 under the care of the state. Mm-hmm. And my own personal editorial, coming from a county board of supervisors, now here, I'm not a medical expert, but there is significant room for improvement within our foster care system. In particular, when it comes to data gathering, tracking, and making sure that youth receive the services they need to thrive. So that's why I ask, when we say we're working on it, does that mean it's in process now, it's a good idea and we should get on it, or that we're actually doing it? Is it all three?
I would say yes, it's all three. There are things we are actively doing. So things like the treatment authorization requests for all antipsychotics for children. There are the quality improvement projects that are working on training and education, the guidelines that were developed. The data sharing agreement where we're now providing data to counties that have signed on to that global agreement. So the 4 counties that have been able to now receive client level data so that they can really close the loop, figure out what's missing in their data system and start to track it down. Those are things we are actively doing, we can point to. It's still a little early to show in the data what the results are of those activities, but those things are actually happening. We're also actively doing things that will improve data collection in the data that we have. But then there's also other things, like, for example, the whole conversation around electronic health records. I think we're all thinking about how do we approach that? What is the best way to invest dollars to support that? That's something that is still very early, and we don't know exactly where we're going yet.
Do we have a cost estimate of what that would take for full implementation?
We'd have to know more about what it is we're talking about implementing.
Okay.
So no.
Okay. All right.
It's the short version.
A couple other questions, and again, I appreciate your patience. Mm-hmm. So what we hear are constant feedback about wait times and access to mental health services. And how does the department track the inability of a youth to access mental health services? So what we've heard is anywhere from 2 to 6 months. Sometimes we hear a year. And I know, and again, I appreciate your patience. how do we track who's getting what when in regards to mental health services?
So through the EQRO process is where we track access, but also we are responsible for reviewing the county plans. The counties then contract with providers, and the counties are responsible for then reviewing their providers and working with their providers on access. So if it's possible with your patients, we could hold off until we hear from Pat Ryan. That may give you a bigger picture of what's happening both at the state level and at the local level.
Sure. And I appreciate that, and I'm looking forward to Ms. Ryan. But I do know that.
Sorry, Pat.
No. I mean, honestly, look, I am not trying to be confrontational on this, but look, we're 10 flipping years into this, and it's not excusable. And we're here to collaborate, but what we can't do is put another study on the shelf, let it collect dust, and have another wasted decade, right?
We agree.
So that's why we're here. The director has been, and I just want to point out, Director Lightbourne has time and time again shared his commitment to be able to work on this issue. And time is running short. And so that's why if I seem like I've lost patience a bit, it's just we need to be able to move on this and not operate in the silos that I believe that we currently are. And that's on not just on the state, right, but that's within the county level as well. So I think that there are challenges in regards to wait times, because we hear that constantly. The other item that I'd like to know if we are tracking is the ability to treat because of the lack of providers. So I think that's another challenge. Are we tracking that in regards to if child is unable to access service because a lack of provider within the region?
One of the challenges of tracking a non-event is that it's hard to capture it because we don't have anything that's capturing that data.
Okay.
So I mean, I really don't know how to get at that right now in our current environment.
Okay.
But it would, I mean, it's the thing we'd all love to be able to track for sure.
Okay.
And our best bet is probably getting at some of what Senator Hernandez referred to in terms of looking at comparison across population groups to get a sense of, are we seeing about the same amount? And so, again, we're working on that analysis, hoping to release that publicly in the near future, but I don't have an exact timeline.
Okay. Great. Is there anything else you want to be able to add to this?
Not yet.
Okay, thank you. And again,
Thank
appreciate
you.
everybody's patience. Would like to be able to turn it over to Mr. Lightbourne, Director of Department of Social Services. Thank you so much, Mr. Lightbourne.
Thank you, Chair McGuire. I want to touch briefly on about 4 things. First, and in a sense, Patrick Gardner and Dane Servine bookended the issue around how the two systems work together, how they integrate, how they hold each other accountable. I had the pleasure, of course, of working with Mr. Servine in the 90s in Santa Cruz, and there in a relatively small environment, a level of sort of voluntary collaboration was almost natural. I mean, anything less would have been unnatural. When one gets to a state level, it is more complicated just by its very nature. And part of what we are now obviously moving forward with in things like AB 403, et cetera, is saying we just have to build in expectations that we're going to hold each other accountable for, and it's not up to being nice. We are nice, we are respectful, we are colleagues, but at the same time, we've got to serve the people whose services are expected, and that's where we're going with it. On the issue of sort of data sharing, et cetera, I just want to emphasize that with the Global Data Sharing Agreement, we do have 4, and I think there's a 5th county about to sign. To some extent, we realized we were feeling our way into this. Last week, we did a webinar with other counties, the counties that have already received data and worked with our data shop on interpretation, presented to their colleagues. There's a lot of interest and excitement, and that's how things get out there. Is that they're early implementers. And we do expect it to produce next steps. Third thing that I wanted to touch on, and I'm going to share copies with the table, and I think it's probably been distributed to the committee and the public. We, over the last month or so, did some trial reviews at group homes to see what the experience appears to be in psychotropic medication utilization, concurrent use of other services, et cetera. And we picked 3 tiers of group homes which, based on the data sharing, it looked like 90% of the youth living there were receiving psychotropics, facilities were 50%, facilities were 10%, just to get a sort of a different sense of scale. And the purpose of this isn't to prove anything. It's more to establish baselines for ourselves as we take the next steps forward so that we start to inform both our questioning and our guidance. So what we see, and I'm not going to read all the data, is that there were treatment plans on file. Most of the youth were receiving concurrent psychosocial services. Again, whether these were the exactly appropriate services for a particular diagnosis, we're not going to call that yet, but it's based on the interviews with the youth. They felt that there were people they could discuss concerns with their medication about. However, they also, there was a majority saying, and either we know or we sense or legend has it that there are consequences if we don't take the medication. And that is of concern. They did report regular contact with their psychiatrists, and as the data shows, in fact, slightly higher than the 64% on more than one medication. Most were on more than one medication. Where we go with this is in the following areas. Clearly, the staff were what we are technically calling childcare staff, were not uniformly familiar with side effects of medication. And so we need to have more training out there on this, and we're working on that.
Can you go in depth on that a little bit?
Partly because of turnover at the group home facilities. There were staff who knew where to go and find and look up information about what are the side effects of a particular medication, but they didn't actually know it themselves. So we would look for a bit more active training in that. Second area is that we want to be sure now that we are completely pushing out the guidelines, prescription guidelines from the Quality Improvement Project. We've had, as part of the Quality Improvement Project, a lot of stakeholders, including the Academy, Child and Adolescent Psychiatry, among others. And so we've developed the guidelines, and now to push them out to be sure that there's common understanding, and then to deal with this question of what seems to be a culture of compliance. We want to we're going to be convening some subgroups from the Quality Improvement Project to look at what sort of guidance we need to give the group homes in this interim period before AB 403 is implemented and we move to the other models. What sort of guidelines around having written protocols around if a youth is reluctant to take medication, what should be the steps followed and what should be their recourse, and just to be sure everybody's on the same the same level with that. Through the foster care ombudsman, we do a lot of trainings in group homes around foster children's Bill of Rights and things like that, but we want to be sure that it's integrated there. And then the fourth thing I just would touch on is obviously the longer-term strategy here is in the changes in AB 403, which, as you know, is now on the Senate side. Very grateful for the unanimous support from Chair McGuire's committee before the recess, exactly the sorts of things there where emphasizing family finding, bringing the services to the family level so that we're not failing kids up. And so because frankly, in almost all of these interviews, youth had entered the group home on medication. It wasn't that the group home had medicated. It was that was the presenting situation. So it speaks more and more to that issue of having the services available in the family, and then very critically evaluating, being sure that we have the feedback loop with the not just an upfront assessment, but a repeat assessment that's capturing progress so that we're not just measuring, do we have process things happening? Was there a referral to mental health? Did they get a therapy? Blah, blah, blah. But rather, is there movement in the child's well-being? Mr. Gardner spoke earlier to CANS. Ms. Baylor said there may be other tools. We're looking at several other tools just to see what is the largest range of standard deviations that we can capture and measure so that we can really see progress, not just sort of on the mega scale, but individual children move sometimes in small steps. And we want to be able to capture that, evaluate that, and know that we're resourcing that which works. And then finally, the sort of the other underlying principle in continuum of care reform in AB 403, which Mr. Savine spoke to, and did not prime him, was the whole issue of the child-family teams and making those sort of that element from the core practice model sort of the standard of care and the standard of service, the child welfare system. But core piece, and I started with it and I'll end with it, is over these past couple of years, both through the KDA implementation, the core practice model, and now the 403 work in legislation, is bringing the two systems together in ways that there really is mutual accountability and transparency and accountability back to the administration as a whole and you as policymakers. Thank you.
Thank you so much, Mr. Director. I just have some questions on a few follow-up items, if I may. I want to talk about the guidelines. You know, a lot's been discussed relating to the guidelines, and I want to first say, big fan of local control and coming off of a board of supervisors. And if there is a voluntary approach to an issue, it's going to be up to the county and ultimately their vendors who they're working with to be able to implement what these guidelines are. Now, essentially, they're best practices that are being pushed down from the state, but we're not evaluating if those best practices are being implemented or carried out. It's a voluntary approach.
Yes and no. The implementation on the part of what are now group homes will be STRTCs to the extent some of them transition, foster family agencies, et cetera. That's not voluntary. Those are entities that the state of California licenses. We're imposing guidelines. They will follow them. The parts that have elements of quote unquote voluntary are practice decisions on the ground in the field. And frankly, again, the difference between operating in a county the size of Santa Cruz and operating state as a whole, you will get better outcomes by and large with that local level. But the second piece is the accountability, the transparency of the data, and measuring the outcomes and the progress, such that if we are seeing situations where we're not getting progress or we can't account for other than claiming lag data or something else like that, why is the investment, let's say in mental health dollars in children's mental health, why is it declining? That's, again, the accountability function that mutually and this way we have to do.
So when we are saying within the guidelines, and correct me if I'm wrong, outline expectations for the development and monitoring of treatment plans, principles for emotional and behavioral health care, psychosocial services, non-pharmacological treatments, principles for informed consent to medications, and principles governing medication safety. How do we measure that if we're not mandating it?
Those are professional guidelines. And both systems are, both the child welfare system and the mental health system are and for that matter, the physician community, the medical board with whom we've shared information, all of us have a piece of that.
No, I appreciate that. And look, there are 56 different systems out throughout the state. And I think that we can all agree there are, in whatever issue you may be talking about, there are some counties that are going to excel, some that are going to do a pretty good job, and some that are going to have some challenges. And what I'm concerned about is this is not a consistent approach. And in particular, when we take a look at these foster youth that are probably the most vulnerable in our system, that have seen incredible trauma, and we are not pushing down these mandates to ensure their success, of course that we're going to have some counties that are going to comply and probably a lot that don't. And so that's where I'm trying to figure out, these are wonderful guidelines, but how do we mandate that the counties are going to row together with us towards success? I don't think we can.
Well, let me speak only to the child welfare side of that equation, because I don't have sort of the remit or the, for other systems. What we do is we have pretty elaborate measurement systems on all 50, not 56, in our case it's 58, all 58 child welfare systems. We have corrective action authority. We have several counties at any given moment with one or another form of corrective action plan to hit what they're supposed to be doing. And God forbid we should ever get there, there are some pretty extreme provisions within the Welfare and Institutions Code that authorize our oversight responsibility over the child welfare system. Those things are in place and followed. To the extent that, well, not to the extent, when 403 is implemented, that will carry additional things into that system, and we will do it exactly the same way. We will be, and we will be building in the assumption that any child meeting medical necessity that needs mental health services, then we sort of move to our mutual accountability system, and we say,
a one-size-fits-all approach, I got to be candid, does not work. So to be able to expect counties that are economically challenged to be able to move forward with a very similar system or maybe a robust system that, frankly, are wealthier, I think that we need to be, my own personal opinion, see a mandated set of minimums that are going to be expected, particularly relating to these guidelines. That's just my own personal opinion. And it's just like anything in life, if you are not forced to comply, you have a lot of priorities that are coming at you during the day. On the mental health side, I mean, how are we ensuring that these guidelines are enforced?
We're going to use our triennial, and then because we are wanting to be more transparent and because of CMS requirements, the triennials will be posted on the website along with the plans of correction, and so everyone will have and be able to see how the county is performing. So I agree with Director Lightbourne that it is a comprehensive and a collaborative approach between the two systems.
Okay. So just what I'd like to be able to follow up on the EQRO, and I appreciate that. Thank you. So I want to get back to the issue of wait times. Again, this is the issue that we continue here, and I know it's more of a mental health side. Department is saying, and correct me if I'm wrong, have not seen a significant challenge related to wait times for access to mental health care.
Correct. We have not had any formal complaints or any issues that are raised. We also hear the same issues that you hear from the providers, but as far as the monitoring, our monitoring of the county plans, we're not hearing of wait times. Now, what we do hear is that if there's some specialty, like you're waiting for a bilingual psychiatrist, there is going to take some time to find that, just because of what we talked about with workforce shortages.
And I hear that. And so just in the preparation, and I'm sure you read the background report, we had 6 examples of some adolescent, some teen that have experienced significant wait times to be able to access mental health care. And we also had 2 individuals that testified earlier when they were within the state system, had challenges to access mental health care. Now, there are different variables behind that, but I think that if we do a deeper dive, that I think we're going to be able to show that there are some pretty significant challenges trying to access mental health care.
And I would love to help you with the deeper dive.
That would be great.
Because The part that's really difficult for us when we read those examples is I don't know what county, and I am happy to talk to the county and find
love to be able to
out
provide that.
exactly what is going on and to see the full story. Also keep in mind that the mild to moderate just was enacted as a benefit this last year. And so in order to see the whole picture of mental health services, I think you have to look at specialty mental health, but you also need to be looking at what's happening in the managed care side. And then we also have the Mental Health Services Act as well that is providing services. And so just really want that global approach of looking at which system were they trying to access. You know, I have a lot of questions when I read those vignettes about what was going on and would love to have the deeper dive and really, we can provide the technical assistance to the county, whatever we need in order to change that.
We'd love to be able to work with you.
That'd be great.
We, as you know, need to be very cautious in regards to identity. But if we can have a confidential conversation, that would be fantastic.
Absolutely.
That would be great, and we'll definitely follow up on that.